Some of the guidelines clearly suggest that the thiazide-like diuretic, which means chlorthalidone, but in particular indapamide, are different from hydrochlorothiazide, and this is clearly supported by the larger efficacy of the former classes of drugs in terms of blood pressure control and prevention of cardiovascular disease. All patients with metabolic disease, and in particular the diabetic patient, have a very high rate of hypertension, and this translates in a very high rate of cardiovascular complication. And usually when you treat these patients not enough aggressively, probably you will increase the rate of cardiovascular complications. So you have to treat effectively, and you have to treat them very early in the natural history of the disease. In terms of pathophysiology, I think that every patient with metabolic disorder, either metabolic syndrome, obesity, but in particular diabetes, deserves some kind of a diuretic treatment because they are typical insulin-resistant state. And the reduction in the insulin sensitivity translates into a retention of sodium and water. It is something that can be treated effectively only by the use of the diuretics. The combination of perindopril and indapamide seems to be ideal. It's ideal from the pharmacological point of view because these patients have on one side an overactivation of the renin-angiotensin system, on the other side a huge retention of salt and water. But it's also important in terms of the results of the trial. And in particular, the Advance own trial have clearly demonstrated that the combination of perindopril and indapamide is the cornerstone of the treatment of the diabetic population. So actually, I think that in this population of patients, as endorsed by the guidelines of the American Diabetes Association, ACE inhibitors and the diuretic, but in particular, according to the evidence-based medicine, perindopril and indapamide must be regarded as the optimal solution.